Hello, good morning. I'm absolutely delighted to be able to welcome everyone to the LongCOVID Patient Conference. I'm Kjell Hansen, the chair of European Lung Foundation, and I'll soon invite the host for today to introduce themselves. But first, allow me to introduce the co-organizers of this event. The European Lung Foundation is working in partnership with European Society, Respiratory Society, to bring patients and the public together with healthcare professionals to improve lung health and advance diagnosis, treatment, and care. Our partner for today is the EAS professionals working in the DRAGON project, a pan-European project that is using artificial intelligence and machine learning to better diagnose COVID-19 and better predict the outcomes for patients. Finally, I want to introduce you to the ELF COVID-19 Patient Advisory Group, who are working closely with our ELF staff to co-organize this event. You'll meet the great people of the COVID-19 Patient Advisory Group later during the day. But first, you'll meet the co-chair, Maarten Ingebretsen.
Hi, Kjell. You should have actually practiced a little bit more on my pronunciation. You should be pretty good at it. Hello, everyone. My name is Maarten Ingebretsen. Sorry, I have long COVID, and I'm a member of the COVID-19 Patient Advisory Group. COVID moved into our house when Denmark closed down and never actually moved out of my body. We are 4 members in my family. We all got it with different outcomes. And before I was ill, I was pretty fit, and I worked out 4 to 5 times a week. I was, for example, doing interval trainings in a stair for 244 steps. Now I am limited to slow walks, and I suffer with breathless and brain fog and fatigue. And if I do too much, I get pains in my chest area, strong pains. And recently I also struggled with nausea and dizzy. My experience has been common with many people around the world, and we are all very worried that we will never become better. There's also a lot of conflicting information about how to treat this. I can say for myself that many of the advices that was out there in the beginning was totally not correct, because I was either doing it before I got ill or so this is why this conference is extremely important to help us to better understand and to learn how to better manage and hear about the latest research. We have had a fantastic response on our conference. Over 1,600 people has been registered. Over 100 countries has signed in. This is absolutely amazing. The conference is also an opportunity for you to engage with other people. We wish you to be interactive as possible, and please say hello in the chat and also tell us where you're from, and ask questions. No questions are stupid. Feel free. But the speaker cannot answer any questions that is personal for your personal circumstances. That's not possible. But please do not be shy. We want you to be able to gain as much knowledge as possible here today. If you're using social media, which I guess since you aren't here, please use and Twitter, please use the hashtag LongCOVID to do it. Now I would like to hand over to my co-chair, James, who would like to introduce today's program. You're welcome, James.
Thank you very much, Maarten, and thank you to everybody who's joining us today. It's fantastic to see so many people join us for this patient conference and from so many countries. But of course, that also gives us an idea of the huge scale of this problem of long COVID, which is what we're going to try and deal with today. My name is James Chalmers. I'm a respiratory physician from the UK, from Dundee in Scotland, and I'm involved in a number of research projects trying to understand more about long COVID as well as the treatment of COVID itself. And it's a great pleasure to be here with you. We've got 3 sessions today, and Marianne and I will be chairing each of the sessions. We'll introduce the speakers. We'll try very hard to keep them to time. We'll ask questions at the end of each session. So you'll hear a sequence of talks, and then we'll have a Q&A for all of the speakers at the end of each of the sessions. Please write your questions in the Q&A box at the bottom of the screen as we go along. Marianne and I will be monitoring that continuously, and we'll select questions that we can ask to each of the speakers. We're fortunate in having fantastic, world-leading, very knowledgeable speakers who know a lot about long COVID, and we're very committed to patient engagement. So we're going to be actively encouraging your involvement as we go through the day. And all of our speakers are really committed to actively involving patients in their research and also in the information that we share today. We don't know everything about long COVID. It's a very new condition. Things are always changing, as Marianne was saying, and so we won't have all of the answers today, but we really want to learn from you. So please post your questions in the Q&A. Tell us what you think. Tell us what we need to be investigating, what we need to know more about. Remember, no question is stupid. Please like any questions in the Q&A that you want answered by using the thumbs up icon. That helps us to see which questions are most important to you so that we can flag these to the speakers, and also helps us to avoid duplication of questions. Today's conference is jointly organised by the European Lung Foundation. The ELF is a respiratory charity, and so we tend to approach things slightly from a respiratory angle, but we know very well that long COVID affects other organs, so we'll be talking about it also in a very broad sense. We'll also try and balance the patient experience with the evidence that's been collected so far from research studies. Hearing patient experience and being led by patients is especially important in long COVID, as there is so much that we don't know about it. So the first session is on what we know about long COVID. Our speakers will also share some insights from patient surveys. Then after a 15-minute break, the second session will look at the latest research into long COVID, and we'll hear from the Dragon Project about a new study that's just getting going. Then after another 15-minute break, we'll conclude with a section on treatment, rehabilitation and support, and we'll hear about the latest treatments for long COVID and find out what happens in a long COVID rehabilitation clinic. So back to Kjeld.
Thank you, James, and thank you for these interesting introductions. So now it's up to me to introduce the housekeeping rules. So today we are running a webinar style event, so attendees can only see the speakers and chairs and hosts. And you are all muted during the event, but you can participate both in the chat and through the Q&A. We will, of course, be recording the events, so talks will be made available on the ELF website and the ES respiratory channel after the event, so you can also access them there freely, or if you missed today, you'll be able to see it then, of course. We will also be providing translated subtitles for the event in case there is a particular language that you want to watch the event in. If there's a language that you would like to see the talks in, then please let us know. So we are already translating to a number of languages, but if you have anything specifically, let us know and we'll do what we can to accommodate. In the Q&A box, please write your questions there, and we'll try to answer as many as possible as we can in the time that we have with all the people sitting behind the scenes. Those not answered, we'll try to get answers to from speakers after the event, and we'll put these on our website for you to access after the event. So keep a close watch to the website as well. On top of the chat and the Q&A, we will also run a number of polls during the event. So there'll be several polls where we'll be asking you to participate in, and I think that we will do a test run now. So you'll see if we're able to complete the polls in a satisfactory manner. So please get ready for the first poll to see who we have attending today. So in the first poll, there are 2 questions. And in the second question, you can choose more than one category. So if we are ready. So good. So we see that there's a wide distribution then in who is attending the event, but there's one category that stands out. So a lot of healthcare professionals are attending the event today, so around 70%. So this could, of course, demonstrate that there's a need for information about COVID or long COVID, not just amongst the patients, but also amongst professionals. So in the second question, choose the option or the options that best describe you. We see that there is a majority that care for patients with long COVID, but there's also a lot of people who have not had long COVID attending the events. And also a significant portion of you have currently long COVID. Also, welcome to you. And I'm very confident that we will be able to facilitate information for all of you attendees. But thank you so much for filling out the poll. It's been very interesting to see your background, and it will help us also move forward for today. So before I hand over to Marianne again, then I think we'll see a map also of the participants and the countries that they're coming from. Here we go. So you will see that there's a lot of people then from a large part of the world. Unfortunately, no one from Greenland, but a large part of the world is represented today. So that is really, truly amazing, and something that we are very proud to have you all today, and to be able to share this information and hopefully engage with you and your questions. So Marianne, welcome to introduce the first session.
Yes. Yeah, it's very impressive, this map here. The first session today is an introduction to long COVID. We would like to share a short video from two patients, Malu and Natalie, where they talk about their long COVID. Thank you.
We just had a bad flu for a week, really bad flu, and we had high fever, and after a week we got a little bit better, and then after 2 days, then it really came, in a different phase. It's like I had a chest pain and heart beating, bam here. It was really scary. I had nausea. I was dizzy. So I could not compare it with anything else.
I felt guilty because there were things I did have that didn't seem consistent with being unwell. Like I had an appetite, and therefore it looked a bit odd that I could eat and quite sort of enjoy food a little bit. But yet I had these other seemingly quite chronic symptoms going on, and this heavy fatigue and this inability to do anything. I couldn't even hang washing out without feeling really, really poorly, kind of thing.
I just finished my psychotherapy study, and I used some of these techniques on myself, and I just took it by the day, really. And I was trying not, and sometimes I lost it. Sometimes when my physics were so bad, like bam, then I got scared. I did get scared sometimes, but most of the times I just try to see, okay, we're not alone. There are a lot of people, they're doing research on this.
I do remember a time when I was really unwell in the night, and I spent a lot of time alone in the night because you're awake, and I had insomnia. Insomnia is there's so many symptoms, a lot of neurological symptoms, but at the time it was being described as a respiratory illness, so it didn't make sense to have all this bunch of symptoms going on around your body, but to be told it's only a cough and it's only a fever, and it's, that was just weird. It was at the point of like a couple of weeks into it that I thought, hold on, all the national guidance is sort of saying this is a 2 to 3 week affair, like it's like flu, and a mild to moderate case should be done after that. And I'm not admitted to hospital and I've not deteriorated. And I was starting to get research, because that's what I do, and figure out what the lay of the land and what cases were looking like, looking at case studies in the press. And people were saying around the day 11, 12 is the critical point where if you're going to go down, you'll go down around that time and into hospital. And I kind of got past that stage, was quite relieved, but I wasn't really getting any better. So that's when I started to think, oh, this is odd. You know, this doesn't really make much sense, I guess. So I had some downtime, which to be honest, there was no option. I had to rest at that time. And I turned down some work because I just thought I need to look after myself and this is not possible to do. So it was a needs must situation. And it was really hard on my family. My kids didn't understand why I was in bed for days on end. I remember my husband saying, why aren't you spending any time with us? You need to spend some more time with us. And me thinking, I just can't physically do it. It's exhausting to play a card game with my children. It's exhausting to do the small, I couldn't read a story to my daughter without like not being able to take a proper breath in between. And that was just awful at the time.
And this brain fog, it's really confusing because you lose your memory. You have problems. I have a good memory from long ago, but these things I'm doing during the day, I just forgot everything and I couldn't find the words. Then you get scared. So what's happening with my brain, and will this get any better? And can I ever work again, or can I be a good mother again? Because I'm just, I cannot do anything with my child. I'm just laying here and.
Where possible, and it isn't always possible, it's kind of saying, okay, there will be days when I feel a bit dizzy, where I feel a bit like this morning, I started to feel like sort of what might be described as a vestibular migraine coming on, where I get screen intolerance. I feel nausea if I look at a screen for too long, and I'll get pressure here that's quite intense, and I'll feel a bit weird, just not quite with it. But I can actually function pretty well. I'm lucky that I haven't had brain fog to the degree that some people have. Some people aren't able to even finish sentences and can't do their jobs, whereas I'm able to do that. But I'm not able to exercise properly, because any exertion that's beyond the norm often has a relapse, or there's some payment to be made a few days afterwards.
And I had a person, woman next door, she was in hospital with COVID. So she was like really ill, but I was at home for 6 weeks laying in a mattress. And first there was the perception that people who were in the hospital, they were only the ones who have severe COVID, and the people that are at home, that they have mild symptoms, but that's not the case.
To be told this, you will recover, sometimes you actually have to just live through it and be comfortable with the fact that you might not know what's going to happen. And that's a fairly big deal for anyone to come to terms with.
I'm getting my life back together slowly. So I take the time for it. So if I learned anything, is taking time. Just go with the flow and just look every month. I did find a new job. So I find a job that's nearby. It's only a 15-minute drive and not 45 minutes. So I am looking at my life. So how much work do I want to do? And the coming year I won't work full time. And then every year or every half a year I just look at it and see where the balance is, where it takes me.
So I think we heard some really powerful descriptions there of long COVID and the impact that it can have on patients. And I can see in the chat lots of people saying that they also relate to those symptoms and those experiences. Everybody's experience is slightly different, and the two experiences that we heard from Natalie and Marlou are slightly different, but really illustrate the devastating effect that this can have. So we're going to dig now in the first session into the impact of long COVID, giving an overview of what we know about the disease. And so it gives me great pleasure to introduce the first speaker. The first speaker is Dr. Betty Raman from the University of Oxford. She's an academic cardiologist and is leading some major research studies into understanding the impact of this disease on patients. Betty, thank you for joining us today, and we're looking forward to your talk.
Thank you, James. As of 7 a.m. this morning, there are more than 186 million cases of SARS-CoV-2 infections across the world. Here is a density map of the COVID-19 cases stratified per country. And what you'll see here is that countries with the highest number of cases are in dark red, versus others that are lighter, have lower cases. Now, of the 186 million cases of SARS-CoV-2 infection, 170 million have survived. And it is now estimated that at least 1 in 10 individuals recovering from COVID-19 are likely to suffer from long COVID. This would take the cumulative tally up to 17 million individuals across the globe. But what is long COVID? Good morning, everyone. Thank you for joining the session. My name is Betty Raman. I'm an academic cardiologist from the Radcliffe Department of Medicine, University of Oxford. In the last year and a half, I've been researching the medium to long-term effects of COVID-19 on holistic health, and would like to share some of the insights gained through this work and my understanding of this mysterious disease. My work here is funded by the British Heart Foundation and the National Institute for Health Research, Oxford Biomedical Research Centre. So what is this mysterious entity, long COVID? So long COVID, or long haul COVID, or post-acute COVID syndrome are terms used to describe the lived experience of patients who continue to suffer the signs and symptoms of COVID-19 beyond the acute infective period. As you will see from this figure here, taken from a NICE review article, acute COVID may last up to 4 weeks from the infection. And beyond this, scientists have not been able to isolate replicating viruses. Therefore, long COVID or post-acute COVID is a term usually or typically reserved for persistence of symptoms beyond 4 weeks. Now, many of us know that there is still no formal case definition for long COVID as yet. There are still debates as to what this condition should be called. But in general, it is safe to say that there is unanimous agreement that this is a diverse and complex disease, which in many ways has marked similarities with other post-viral syndromes and chronic fatigue syndrome. So what are the range of symptoms that people may experience as part of this disease? Well, there are now more than 4 dozen surveillance studies in the literature which have really captured the multifaceted nature of this entity. And needless to say, social media has played an important role, wielding its power in a positive direction for change, to bring to light the suffering of patients recovering from COVID-19. Many individuals feel like they've been forgotten and have been let down by the healthcare system worldwide. And what are the symptoms that people experience as part of long COVID? Well, one study by a patient-led research group by Hannah Davies and colleagues, published as a preprint on medRxiv, has shown us that individuals with long COVID can report more than 200 symptoms at various time points during the convalescence. The symptoms experienced by patients often tend to span across multiple organs, and virtually every system can be affected from this disease. Of the many symptoms reported, the ones in dark or deep blue or Oxford blue are the more commonly experienced symptoms, and these include fatigue, difficulty breathing, brain fog or difficulty concentrating, muscle or body aches, cough, palpitations, diarrhea, congested nose, and the list goes on. So for those individuals recovering from the acute illness, the question regarding long COVID is no longer what if, but more like when. Because we really are dealing with a major health disaster here, which, as I've said before, should be treated no differently to a pandemic on its own. Nonetheless, it's worth noting that there are some differences between long COVID and the acute infection. Because unlike COVID-19, which is caused by a simple virus, long COVID is believed to be an expression of the human body, either in response to persistence of virus or as a result of a confused, hypersensitive immune system attacking its own self. And the human body is far, far more complex than the virus. So this disease really highlights the gaps that are present in our knowledge and underscores the need for us to think of the body as a whole and understand how the various organs talk to each other, to the immune system, and the blood vessels. And for the first time in the history of science and mankind, we've got experts from various disciplines coming together to selflessly crack the code and understand the mysteries that underlie long COVID. What are the risk factors for long COVID? Well, we know from data collected from the Office of National Statistics in the United Kingdom and multiple other large prospective studies that a number of risk factors are found to strongly associate with long COVID. Being female, for example, can increase the risk of developing long COVID by a factor of 1.5. Other risk factors are also present, and these include escalating age, pre-pandemic mental health, asthma, comorbidities, obesity, and in some studies, the severity of infection. But why do we see such a wide range of symptoms? Well, one possible explanation is that there may be factors affecting multiple organ systems simultaneously. So to understand this, it's worth recalling and reviewing the many different ways by which the virus can cause damage in the human body. We've known for some time that although the virus primarily affects the lung, that it can cause injury to other organs. And this is because the virus penetrates the cell using its spike protein, which acts like a key to unlock the door into the cell. Now, this door is called the ACE receptor and is found on the cell surface of multiple organs. And therefore the virus can enter not just cells in the lungs, but also in the heart, the liver, kidneys, blood, and brain. There are some very elegant experiments using cell culture models, animal models, that show precisely how the virus enters the cell, replicates within the cell, and causes havoc to the internal machinery. The second route is by damaging the inner lining of the blood vessels. The inner lining is called the endothelium, and under normal circumstances, the endothelium is very important. It releases substances that relaxes the blood vessels, keeps the blood flow going, preventing it from clotting, and even protects the organs from the immune system. But when the endothelium is damaged, this increases the risk of clotting and can activate the immune system. Now, a third mechanism is triggering or activating the clotting mechanisms in the bloodstream. This can make the blood sticky and can cause clots even in blood vessels where the endothelium has not been affected. A fourth is due to an hyperactive or hypersensitive immune response, which is either trying to clear the virus that may linger in some of the organs, or could be an exaggerated maladaptive response of the body, which eventually starts affecting itself or attacking itself. What is interesting about all these four mechanisms is that they can affect all the organs, and this is why it remains important to have an open mind about what might be causing long COVID in individuals. But is long COVID just another post-viral syndrome or a form of chronic fatigue syndrome? So let's talk about post-viral syndrome first, starting with the 1918 Spanish influenza pandemic. There are plenty of stories from the early 1900s where patients recovering from the flu were bedridden for weeks and months beyond the acute illness. How about the SARS outbreak? Well, after 2003 SARS pandemic, more than half the patients who survived the initial infection reported post-viral fatigue up to a year following the diagnosis. These symptoms of fatigue did not occur in isolation, but was associated with other symptoms, including sleep difficulties. Of interest, even by 4 years follow-up, up to 40% of survivors reported chronic fatigue, and nearly 1 in 3 met the diagnostic criteria for chronic fatigue syndrome. How about 2009 influenza A? Well, researchers in Norway studying the lasting symptoms of the flu pandemic found that this infection was associated with a greater than 2-fold risk of chronic fatigue syndrome. Some of you may have read about the effects of the Ebola virus. Many patients following this infection report prolonged periods of fatigue, joint pain, muscle pain, headaches, eye problems, and sleep disturbances. Finally, there are many studies attempting to associate Epstein-Barr virus and the human herpes virus with persistent fatigue. What about chronic fatigue syndrome? So as a disclaimer here, I'd like to point out that I'm not an expert in chronic fatigue syndrome and probably don't understand it completely. However, it's worth reflecting on the experience of those who are currently living with CFS. As many individuals suffering from CFS have looked at long-haul COVID patients and have commented on the marked similarities between the two conditions. They say that it is like looking in the mirror for us. To begin with, many of them have had a viral infection that led to their symptoms: a week of exhaustion, post-exertional malaise, nausea, pain, persistent dizziness. There are just far too many aspects that are common between long COVID and chronic fatigue syndrome. And therefore, it is really important for us to engage with patient support groups like ME Action, Body Politic, the long COVID support groups, and work together as these bodies act as advocates for long haulers and educate the public health system and doctors across the world about the experience of long COVID sufferers. Now, there are many out there who believe that the term long COVID should be reserved only for patients recovering in the community and not for those discharged from hospital. The arguments in support of this are derived from the intensive care literature and papers that describe the recovery or journey of patients, of individuals with critical illness. Now, patients who were admitted to hospital may have received ventilation or other therapies that could affect the organ system. And indeed, these therapies have been shown to be associated with more long-term damage. However, what we do know is that COVID-19 survivors who leave hospital and those recovering from community actually describe very similar symptoms at 3 to 6 months and at 12 months from discharge. And therefore, there is still quite a lot in common. There's still a huge overlap between the two communities, and forcing a distinction between the two undermines the importance of one or the other. So what about evidence of abnormalities on objective tests in long COVID patients? Well, over the last 6 months, there have been a series of large retrospective population cohort studies published in journals like the British Medical Journal and Nature, so reputed journals, that looked at data from electronic medical health records. In an American study of 73,000 non-hospitalized individuals with COVID-19, Ziad and colleagues demonstrated that beyond the first 30 days of infection, COVID-19 was associated with a higher risk of neurocognitive disorders, mental health disorders, metabolic derangement, cardiovascular diseases, gastrointestinal diseases, malaise, fatigue, musculoskeletal pain, and anemia. In another UK-based study led by researchers in University College London, analysis of electronic health data from nearly 48,000 hospitalized patients with non-hospitalized controls showed that a diagnosis of COVID-19 was associated with a higher risk of diabetes, MACE, and renal failure, up to a median period of 3 to 4 months from infection. What is interesting is that in this study, the risk was not confined to the elderly and was actually more pronounced in non-white patients. Other abnormalities in objective measures have also been reported in prospective follow-up studies of predominantly hospitalized patients. So one put out by investigators from Wuhan, China, found that up to 50% of patients followed up at 6 months had abnormalities involving lung CT. Another study by a UK group in Leicester followed up 1,000 patients who were admitted to multiple hospitals across the UK and reported that somewhere between 22 to 50% of survivors of COVID-19 had impairment in gas transfer, which is an important component of lung function. And of course, they also found abnormalities on routine blood tests, with up to 13% of patients having significant renal or kidney impairment and 7% with signs of cardiac involvement or damage. Now, many of you have heard that there are more advanced and sophisticated measures that can detect organ injury. In particular, magnetic resonance imaging has emerged as quite a powerful technology. And to give you an example of this, at Oxford, I'm leading a multi-center MRI study along with Professor Stefan Neubauer, who's the head of our department. This study is called the CMOR study. And we work alongside FOSS-COVID, the national follow-up study, to characterize and provide deep phenotyping of individuals or patients who are recovering from COVID-19. In an early report or early review of our results, we have shown that 1 in 3 patients recovering from COVID-19 had abnormalities on MRI of multiple organs at about 3 to 4 months from the onset of symptoms. And of course, the study is still ongoing, and it's anticipated that we should have the results of deep MRI phenotyping in 500 patients who have been discharged from hospital. In parallel, we're also undertaking another study along with researchers in UCL to understand the burden of multi-organ injury in patients recovering in the community. So, so certainly do watch this space, and I shall update everyone on our findings in due course. Now, some have asked if there is a link between long COVID and multi-organ MRI abnormalities. There's another study called the CoverScan study, which has actually looked into this in mainly community patients. And the investigators of this study observed a clustering of symptoms of long COVID in patients who had MRI evidence of abnormalities involving multiple organs. So to conclude, long COVID is a really diverse and complex disease, which is still poorly understood and presents a substantial burden for healthcare services globally. We have already identified some risk factors that may be responsible for enduring symptoms, such as the sex of the individual, age, comorbidities, presence of certain diseases in particular, like asthma, obesity, and the list goes on. However, what is not clear to us is the underlying pathophysiological mechanisms that actually cause these symptoms. And understanding this would be really important, as this is what is going to pave the way for definitive treatments for patients recovering from COVID-19. Also, effective immunization programs are really needed to reduce transmission and infection. COVID-19 has highlighted the grave inequities in access to vaccination and standard or decent healthcare. Medical communities and healthcare systems should really start acknowledging long COVID as a next major health disaster. Just because we don't understand it, just because we can't explain it, it doesn't mean that it doesn't exist and that it will disappear tomorrow. We really need to be more effective with our strategies to manage long COVID, and there's a need for an integrated healthcare system which incorporates multidisciplinary services to successfully limit and treat the long-term sequelae of COVID-19. Thank you very much.
Thank you, Betty, for this very interesting presentation. I think I will need to re-listen again. Luckily, it's a recorded session because with my brain fog, it would be nice. This is an introduction to the next talks, and it's a result of patient survey from long COVID with Maarten van Herck from Longfonds in Netherlands and Krisnah Poinasamy from the Asthma UK and the British Lung Foundation. I hope I pronounced the names fairly okay.
I will start sharing my slides. Thank you for the introduction and thank you for the invitation to talk during this conference. The upcoming 10 minutes, I will talk about the patient surveys we did with our research group in patients with long COVID. So based upon the severity of infection, patients can be classified as either being hospitalized, and they are often called moderate to severe cases, or patients who recovered at home, and those are often referred to as mild cases. And in the beginning of the pandemic, we were mainly focused, or the world in particular was mainly focused on the hospitalized cases, although this is only a minority of the total cases who were infected. And somewhere around spring 2020, the first evidence about long-lasting symptoms in patients with COVID, and more specific in patients with who were hospitalized for their acute infection, trickled down. And a lot of us researchers were worrying about, but what about the non-hospitalized patients? Are they also suffering from the long-lasting symptoms? And is this maybe just the tip of the iceberg? And the upcoming days and weeks, more and more anecdotal evidence appeared in news outlets about long-lasting symptoms after COVID infection, and also so-called mild infections. And the amount and also the extent of online peer support groups arose from all over the world on several platforms like Twitter and Facebook. It increased enormously, and patients try to connect with each other, but also share their story and find recognition. And with some of these groups, we work together with the for this research project. And I will recommend it to all researchers who are listening, because it's really important. They are the experts, so and they have the lived experience, so please include them before your study, but also during and after. And in our study, we had several aims, and the aims were to characterize long COVID on the one hand and gain insights in the impact of long COVID on quality of life, work, and functional status on the other hand. And we recruited patients via online patient support groups in Belgium and also in the Netherlands. And therefore, we do have indeed a selection bias, but although we could answer our research questions. And the study was twofold. So we had a two-way follow-up survey. And the first survey was released in the beginning of June. And people who responded to the first survey also were contacted for a follow-up survey 3 months later. And in total, about 2,000 respondents answered the survey, and the majority of them were non-hospitalized patients. And only a minority of the non-hospitalized patients received indeed a diagnosis via nose swab or a scan. And the majority actually had a formal diagnosis based on symptoms by a medical doctor, or just on self-report they suspected to have COVID-19. And if you take a look at the clinical characteristics of these patients, you can see that they were relatively young, a mean age of 47 years old. They had, or 60% of them had no illness before infection. And the majority, 85% of them reported a good self-reported health before infection. And if you look at the symptoms they reported during the acute infection, you can see there is an extensive list of symptoms. And also, the list was not long enough. A lot of people reported other symptoms, and this highlights a heterogeneous presentation of COVID-19, and that the symptoms can vary a lot from patient to patient, as already Betty told us. But if you compare the data from the acute infection with the data from the first survey and also the second survey, you can see that the prevalence of symptoms really decreased. So the length of the bars are in gray and blue are really lower than in comparison to the orange ones. But there isn't that much change between the blue and the gray ones. So little improvement in symptom prevalence was found over time in this population. And if you take a look at the symptoms itself, you can see that fatigue is by far the most common symptom in patients with long COVID, and it's highly prevalent. And we assessed it with a specific fatigue questionnaire in this patient. And this fatigue questionnaire that can range, and you can see it in the right corner, from 8 points to 56 points. And the higher the score is, the more severe the level of fatigue is. And these patients with long COVID reported that approximately 3 months after infection, a score of 48. And at 6 months after infection, a score of 46 points. If you know the scale, and it's ranged from 8 to 40, to 56, you can see that the level of fatigue is really high, and there is a high level of intensity of the fatigue. And over time, we saw a little improvement upon fatigue level. But also, besides the fatigue, also other symptoms are really common, like the shortness of breath and the headache. But the symptom list is much, much longer as this, and it's not just limited to pulmonary related symptoms itself, but it's a multi-organ disease. So it implicates also several symptoms like muscle pain, joint pain, the dizziness, nausea, the loss of smell and taste, etc. But what you can see is that also 1 out of 3 people indicated they had other symptoms than our extensive list we put together with patients. So, and these symptoms could be like sleeping problems, brain fog, concentration problems, memory loss, but also hair loss, etc. And this indicates the heterogeneous presentation of long COVID itself, and it really can vary from patient to patient. And despite the little to no improvement in the prevalence of symptoms, a large proportion of our participants did receive some form of aftercare. And 80% of them had received healthcare from at least one medical professional at 6 months after infection for Aftercare, and 2 out of 3 received at least one care from at least one allied healthcare professional, and in particular it was mainly a physiotherapist and in lesser extent a psychologist or a dietitian. And only a minority was referred to a RIA program. But what about the impact of long COVID and the symptoms on quality of life? And here you see a quality of life questionnaire, and you see 5 domains: mobility, self-care, daily activities, pain and discomfort, and anxiety and depression. The first thing that stood out is that the domain of self-care is only in a minority of patients impaired. And this is good news. But daily activities and pain and discomfort were highly impaired, and about half of them, about half of the patients, reported moderate to extreme problems on these domains at 6 months after infection. And remember, these people were really relatively young and had a good self-reported health status before infection. So the impact is high. But what about work? And given the relatively young age of our participants, work is really interesting. And what you can see is that about 3 months after infection, 73% of all work time was missed due to their ill health. And after 6 months, this improved, luckily, to about 50% of all work time was missed due to ill health. So there was an improvement, but if people went to work, they still suffered from a high amount of impairment while working. So their time working was less productive in comparison to normal. And at last, we also asked patients about their informations and care needs. And here you see a word cloud, and the bigger the words are, or the bolder they are, the more they were indicated by the patient itself. And I highlighted some of them, like recognition and understanding, because most of them are poorly understood by medical professionals, but also employers, colleagues, and other caregivers. So for them, this was really important. But also they had lots of questions about the aftercare, how it will, how it looks like, when I will get aftercare, will it help? How long is long term, and how long will my symptoms last? And how is recovery looking like? So lots of questions that remain unanswered, and hopefully today will bring us some answers already. And with this, I will end my talk. And to conclude, so long COVID is really a heterogeneous disease, and it can vary a lot from patient to patient. It's not limited to severe COVID-19 alone, and it has a significant impact on daily life and activities, quality of life, but also work. And understanding and being understood is an important first step, but more needs to be done. And with this, I will thank you for your attention.
Thanks, Maarten. I'm just going to share my screen. Hopefully everyone can hear me. So first of all, obviously, thank you to the European Lung Foundation for inviting us to speak today. A lot of what I'll say is hopefully going to chime with what Betty and Maarten have said, but hopefully that's a good thing. It's sort of about reinforcing messages. I mean, I think one of the main learnings over the last year is just how little we knew. So Asthma UK and the British Lung Foundation actually started work on long COVID back in March 2020. So as Betty alluded to, it's actually early studies from China that was showing us that there was lasting damage to the lungs, and that made us think, okay, well, there's something here that could go beyond COVID, and would be something that us as a charity needed to work on. But at that time, all we thought was that long COVID was about breathlessness. We didn't know much more. So what we did in response was, the first thing we wanted to do was actually create a way for people with long COVID, particularly long COVID breathlessness, to communicate with us. So we created a new website called the Post-COVID Hub in early April 2020, and that reached over 100,000 people primarily from the UK. But it's also a way of us receiving information from people with long COVID. And, I think that's got to be my central message is we really need the views of people with long COVID, because this is a new syndrome. We're not going to know exactly where to focus strengths in terms of support or research without the input from people with long COVID. And I'm going to go over some of the insights that we learned from people over the past year. So we created that website. We've had insight from 4,000 people with long COVID breathlessness. And in addition to that, we've been working as part of FOSS-COVID, which Betty mentioned, which is the largest national sort of flagship study looking into long COVID. It's focusing on 10,000 people who were hospitalized, but it's obviously connected very well with other studies that are looking at long COVID in the community. And I'll come on to this a bit later, but as part of that, we've overseen an exercise where we've tried to understand what are the priorities for future research and taking into account the views of people with long COVID. And throughout all of our work, we've been working very closely with people with long COVID. I mean, I feel like I'm pretty sure I speak to people with long COVID almost on a weekly basis. And in particular, my thanks goes out to people with long COVID as part of the long COVID support group, which has about 40,000 people, and Maarten mentioned earlier. And just as a bit of a, and this may be stating the obvious, but this is what we were hearing back in probably about April 2020. So people who had COVID early in the year and were saying that months later, they still had breathing difficulties, aching in their limbs, and extreme exhaustion all the time. And it was then we were starting to understand, wait a minute, this isn't just about breathing problems. So through some of that work, so through the post-COVID hub, we actually started to gather information on what people were experiencing. So through the survey of about 4,000 people with long COVID, we were getting this information of the wide range of symptoms that people were experiencing. And of course, it wasn't rigorous research at that point. It wouldn't be right for us to sort of ascribe different percentages to these different symptoms, but it was more that sense of an enormous range of problems. And I put a link to some of the early findings that we had, and including a Miro board, which is basically almost a sketch of the journey of people with long COVID from their initial COVID symptom to experiencing long COVID to their attempts to reach out for healthcare. And this is another key message, I think, about long COVID. It's not simply that one has long COVID and it's a steady, I suppose, range of symptoms or debilitation. It's actually that the symptoms come and go. And this is really something quite important, I think, that quite often people with long COVID have told us that they seem to be getting better. And just when they seem to be getting better, actually then their symptoms return again. And in particular, Betty mentioned how people with long COVID, there's a kind of high prevalence of women with long COVID. She mentioned 1.5 times more than men. And it's actually women who've been telling us that some women, their symptoms fluctuate along with their menstrual cycle. And that's valuable information for us, because then that helps us to understand, okay, well, if that's the case, then that might be an avenue for research. It might be something that healthcare professionals need to consider when they're thinking about people with long COVID, i.e. that it's not simply a case of a single treatment and then that's it, and someone's recovery is steady. It is not steady. And then also something that Maarten and Betty both mentioned was this impact on people's lives. I mean, to me, it's been shocking and disheartening to hear how people with long COVID have lived the past year, and a lot of the people I speak to have been out of work and yet trying to fight for someone to be hearing them, someone to acknowledge that their experience is actually something that demands attention and demands a response. If you think back to even, I would dare say, May last year, people weren't really even talking about long COVID. We thought something was happening, but there wasn't really the research set up to look into this. But I think that touch point with employers, and I think someone in the chat also mentioned this, is something that as a society, there needs to be a recognition that long COVID is occurring. I don't know if that's, I'm speaking too slowly and someone's just moved that. This is almost reiterating this point around insights from our surveys in terms of the impact upon work. So 75% of people, and this all chimes with the 2 videos that were shown right at the beginning of today's conference, but the huge impact on people's work, the range of symptoms, but also the fact that a lot of people are reaching out to their healthcare system and either they're not getting any diagnosis or they are being turned away from care. And then I just wanted to talk very briefly about FOSS-COVID. So this is the major study that is looking into long COVID in hospitalized patients, 10,000 people with long COVID. And it involves a range of different working groups looking at the different symptoms of long COVID, but it also involves the charities who are bringing their insights into how people, let's say with breathlessness or with problems with their kidneys, might be supported. And so it's almost trying to not start from scratch, but what can we try and do to help people? And how can we make sure that their voices are heard within these working groups? And so as part of this work, we undertook a prioritization exercise. I won't go into all the detail, but it was about us trying to understand, okay, so what do we need to focus on? This is an urgent health issue about which we know very little. So where should we focus our efforts? And key to this was getting the views of people with long COVID. So those working groups that I had on the previous slide, they were working with people with long COVID to understand what are the right questions to be asking. And they developed 115 questions, which then were sort of reduced down to 24 overarching areas. And then we put out a survey for people with long COVID. So we reached 900 people with long COVID, both hospitalized and in the community. Again, to sort of Betty's point about it's not really wise to be distinguishing between the two. We need to try and get the views of both. And then following that survey, we then looked at 17 questions. So that's both with academics, clinicians, and people with long COVID, to then get to 10 priority questions. And those questions will be released into a publication in the next month, we hope. But for now, I just wanted to share some of the broad areas that are being discussed. So this isn't everything, but I just wanted to share, I mean, perhaps these aren't even controversial, but this is what people with long COVID and the academics agreed on where we should be trying to focus. So the causes of long COVID, outlook for health, trying to have some tests to monitor progress and understandably treatments, because a lot of people have had long COVID for a year plus and have had nothing to help them. So there are more areas, and hopefully within the next month, we'll release a publication and we'll share that with the European Lung Foundation, and hopefully we can tweet about that in due course. So finally, I just wanted to share some of the work that we've been doing to help people with long COVID. So the British Lung Foundation, we've created some support for people with breathlessness, and you'll find that at this website here, and hopefully that can be of help to people across Europe. But also in the last couple of months, we've actually developed a partnership with NHS England, our healthcare service, and we're actually partnering with charities to deliver a service for people with long COVID. And what that will entail is trying to develop a simple framework to describe people's symptoms. So one of the challenges has been, or that we've heard from people with long COVID, is they're telling everyone over and over again, I've got fatigue, I've got breathlessness, I've got muscle pain, and they don't have a sort of framework to work from to understand whether this might be long COVID or something that they can go to their healthcare professionals to have a conversation. So we're helping them with that framework to describe their symptoms. We're providing support, as I mentioned, on different symptoms. So recognizing British Lung Foundation can support with breathlessness techniques. The British Heart Foundation will support on cardiac symptoms. And hopefully this will all be public in the public domain. Hopefully this will be of help to people across Europe in terms of at least seeing how we're approaching support for people with long COVID. And ultimately, we want to see better engagement with the health service, but also with employers, because I think that's a huge part of the story, as I said earlier, is that getting that recognition of long COVID is really key, so that when people are either experiencing that fluctuation of symptoms or actually having to take some time off work because they are struggling with their brain fog, that's really key, and there are services available. Just on that last slide, I just had my contact details. Like I said, the key message here is that none of this can happen without people with long COVID explaining, what their experiences are, and then that informing the support and the research that happens. So please feel free to reach out. Thank you.
So thank you very much to both Maarten and Krisnah for those really important presentations, including the patient surveys. We're going to now move into the question and answer session. So we're going to move into, we're going to welcome back some of our previous speakers. We're going to welcome back Betty, and I'm also going to introduce Danny Altman, Professor Danny Altman from Imperial College, Professor of Immunology, who's going to be joining us for all of the sessions today, all to take part in this question and answer session. So if we can ask all speakers to put their videos on, and we'll start with asking the first question. And I'm going to start with Betty, because this is a question we'll start thinking about mechanisms of why things are happening in long COVID. A number of questions in the chat about why patients get brain fog and what we can potentially do about brain fog. So Betty first, anything from the research on multi-system involvement that explains this phenomenon?
Thank you, James, and thank you for the questions. So the insights that we have from our multi-organ imaging study are quite interesting. So I did mention very briefly that we saw abnormalities on MRI, which were basically suggestive of potential inflammation-related changes. And the reason for that is we looked at the correlation between objective measures of tissue health on MRI and blood biomarkers of inflammation. So it is possible that there is a form of grumbling inflammation that is ongoing, that is contributing to the way people feel. As for the question on brain fog, well, so that's also an important question because this is a very common symptom. Currently, we have not seen an association between the MRI markers in our cohort, but there has been a paper that was put out by the UK Biobank, which is a nationwide follow-up sort of biobank that undertakes comprehensive assessments, blood tests, questionnaires, and imaging of people who are willing to participate. And the UK Biobank had MRI scans of people before they had COVID and after COVID, and a lot of other assessments. And they have seen changes on the brain to suggest that the gray matter volume in some parts of the brain reduces in size or shrinks. And actually, when you look at other disease models that have similar findings, so they're seeing similar changes in diseases like Alzheimer's and Parkinson's. So there is obviously there is a working hypothesis that whatever is occurring in patients who are suffering from long COVID, may predispose them for longer, more permanent damage. And we really need to understand why this is happening. And there's definitely some markers on imaging to suggest this is happening.
Okay, I think that's really useful. I think that'll be of great interest to many of the people asking the questions today about So brain fog has come up again and again in the chat and the Q&A. So I'm going to bring in Danny on this as well. Based on what you've seen so far, are there any clues in these studies that Betty's talking about, or other studies that would give us an indication of how we might be able to treat brain fog or the neurological effects?
Sure. All I'd add to everything that Betty said is that, we all agree that we're talking about a multi-system, multi-organ disease. And when immunologists talk about that kind of stuff, the brain is no different to any other part of your body. So, if we think that there are white blood cells that can release things that are pro-inflammatory and making you feel rubbish, things like tumor necrosis factor and things like that, if they can do it in your kidney and your lungs, they can certainly do it in your brain as well. So we don't need special explanations for brain fog. We can use the same ones, and we can probably use the same kind of drugs once we sort out which are the right ones to give.
Yeah, so staying with that, so from Maarten's survey and also from Krisnah's data, this seems to be a very diverse condition with lots and lots of different symptoms. Is that to be expected even if the mechanisms are quite similar, as you're suggesting, Danny, or does it suggest that there's different mechanisms at play in different people?
So I accept that long COVID is a work in progress, and there are kind of stratifiers and there are lumpers, and that's the nature of medicine and trying to write the textbook in real time. For my part, as I'll try and explain in my talk, the immune system is all over your body and doing things all over your body. So I feel like I don't need lots of different explanations. I can probably work with a small set of explanations, but I'm open.
Okay, so Krisnah and Maarten, one of the other questions that's come up a lot in the chat, I think patients are looking for a bit of hope. How often, based on the surveys and based on what you've seen from the reports, how often are patients getting better? And do you have an indication of how long it's taking?
I have to say, we don't from the surveys. I think it's been, I think I can speak from personal contact with people with long COVID. So the long COVID support group that has contact with 40,000 people, I think they have seen that some people have at least been able to return to work gradually. And I think one of the videos, Marlu, I believe, was mentioning how she had gone back to work. So if that might be a small marker that some people are seeing some improvement from those early days. But for the people that I've spoken to, it has taken the best part of a year, and I know that's not that might not sound like hope. What I would say is that I've never seen anything like this in terms of a response from the research community to try and understand what is going on, to try and understand treatments. We're seeing publications written in record time, and as soon as something is ready, it is out there. And just to the point of earlier around stratifiers and lumpers, I guess that is something, at least, that COVID has released a paper, and I'll put it in the chat in a second, but that at least for that, their early analysis of the first 1,000 patients in that study, we were seeing at least 4 main clusters, and hopefully that will lead us to understanding, okay, well, maybe it's some people with a certain range of symptoms will respond to certain treatments. I don't want to sort of promise more in terms of what will happen, but people are working day and night on this.
Yeah, and I think that's a great message. And Maarten's one of the people who's working. So Maarten, any thoughts on trajectories of recovery or anything early on about characteristics of who gets better?
Actually, it's still early to say something about that, but I think we need to, about recovery, I think we need to ask our patients the questions if they feel they are fully recovered in comparison to before, after and before the infection, because nowadays we are always looking at just the amount of symptoms that are prevalent, but sometimes some symptoms were already prevalent before they got infection. If they had some like comorbidities like COPD or asthma, they are often suffering from dyspnea or shortness of breath. So I think we need to have like a good case definition about what is long COVID, and we are still, I think the researchers are still finding out this case definition. If we can speak, if we say someone is really recovered or not, because nowadays we are just based on symptoms. I think a good definition and good criteria are necessary to say something about the trajectory and if there is real recovery or not.
Yeah, important point. Danny?
Yeah, can I just sort of add a point and make a plea that I think we all agree that the timeline to recovery is one of the most critical questions. And it's the thing that people most desperately need to know. Is this a 1-year question or a 2-year question or a lifetime question or what? And it's the one where the researchers and clinicians really lean on all of the patient-led support groups who have been the research leaders in this, because it's very hard for clinicians to gather the data. Because if somebody just drops out and leaves, is it because they lost interest, they got better, they died? We don't know. So we really lean on the support groups for that data, which is absolutely critical to understand the kind of decay curve of the symptoms and get a feel for, does it look any better at 6 months or 12 months or 18 months?
Yeah, completely agree. And I also completely agree with the comment that it's been the patients that have led all of the driving of this research agenda, which has been fantastic. Marianne, do you want to ask any questions?
No, I don't want to really I just want to say that I've been struggling with this now since end March 2020. And I've tried a different approach, trying just to work out and get better. Then I realized that was not really working. Then I'm trying to rest. I'm not sure that works really either. So you are kind of left in between. You tried, regardless of what I try, I'm still left in the same state, kind of. Slowly, I probably get better, but I don't know exactly what it is that I do, or if it's just the illness itself. And I think it is extremely frustrated.
Yeah. So, and that's a message that also came through in our earlier patient presentations. I think this frustration is clearly a big part of this, and a plea for understanding in several of the presentations today. I can see at the moment the top rated question is a question about potential reinfection. And I'm going to broaden this question a little bit to also ask you about the vaccine and whether people with long COVID should be encouraged to get the vaccine. So the question that's in the chat is, are people with long COVID more at risk of reinfection? And the counterpoint to that is if you could address the question of vaccination as well. I'm going to throw that to Danny because that's definitely got an immunology flavor.
Yeah, no, this is definitely my cup of tea and the kind of research that we and other people have done. So let me first of all talk about reinfection. So everybody on the planet who's ever had natural infection with SARS-CoV-2, we know that maybe there's a tail end of 10% of people who've got the lowest immunity, who have the kind of normal, de novo risk of getting infected all over again. And so how does that apply to people with long COVID? So my experience of people with long COVID is that there are some who feel they may have got it because they had too little immunity, and some who feel they may have it because they had too much or hyperinflammatory immunity. And from what I've looked at so far, I'm not totally convinced that either of those are necessarily explicitly the case. So I take that to mean that somebody with long COVID has precisely the same risk as anybody else on the planet of getting reinfected. So so it's no more or less a worry than any of the rest of us on the planet. So make of that what you will. And obviously lots of discussion about vaccination and long COVID, and the first major controlled trial is underway at the moment. Well, a few of them, one in the UK and one in the US that I know about. And from some preprints that are out at the moment on surveys, again from the patient groups, my reading of the data so far is that of everybody with long COVID who's been vaccinated, perhaps 40 or 50% report improvement, at least in the short term, and the rest are divided between the ones who say they felt worse and the ones who felt no different. So I think that's a work in progress as far as I'm concerned.
Yeah. Does anyone else want to come in on that, on either the immunology or the vaccine side? No. So another question that's coming up a lot in the chat is about the impact of exercise. So patients are sometimes being told to exercise, but they're finding exercise absolutely exhausting, worried that that feeling means that they're doing harm to themselves. I'll start with Krisnah and Maarten, whether that sort of concern over exercise is something that's come through in the patient surveys, and then ask Betty from a multi-organ point of view what we think's going on there.
Yeah, I mean, I think I can say it's absolutely something that we're hearing from patients, that they're constantly seeing on TV, oh, well, you know, exercise will always make you better. And for them, it's not. And I think that's been reflected in some of the studies as well. But yeah, absolutely something we're seeing.
Maarten, anything to add?
Yeah, we didn't ask it in our questionnaire itself, but we left like an open text field so they could give some answer that weren't in the list, and we saw a lot of post-exertional malaise passing by, that people did some exercise and got a relapse afterwards. So about exercise and recovery, I think some people will benefit from it, but it will depend on the patient itself. So not everyone need to do exercise, not everyone will benefit from it, but some maybe will benefit from it, and it's not black or white, and that's a difficult thing, and long COVID is new, but we need to be cautious about that. Some people are telling us that they are experiencing some relapse, so we need to be cautious about that as a therapist, but also we do not have to exclude everyone, because maybe some will benefit from it.
Yeah, and so Betty, do we know anything at the moment about the mechanisms of that? So you made in your talk a nice distinction between the hospitalized patients and the effects of being in hospital versus the effects of COVID. And we know people who are in hospital get muscle wasting and deconditioning, and exercise is kind of our routine treatment for post-hospital rehabilitation. So do we know anything about the mechanisms of why this seems to be different for some people?
Yes, so absolutely, James. I mean, I think it really comes down to it is going to be quite a heterogeneous group of individuals, in the sense that there will be some people who will benefit, and I suspect when we look at the ICU literature and patients and data from patients who have received rehabilitation from being in hospital for a long time, it would appear that those who are admitted to hospital may actually have a stronger benefit from ongoing rehabilitation. And the reason for that are many. When you're in hospital for a long time, there's wasting of muscles, the muscles themselves that have mitochondria, which are little power cells, start getting depleted of the mitochondria. And of course, there's effects of therapies. So for example, steroids can result in wasting of muscles and just the acute stress of illness. So what a number of studies have shown in other diseases where people have been admitted to hospital for a long time is that rehabilitation really helps restore the mitochondria, restore the muscle bulk, restore muscle health in people. And it does seem to help some people, but it's not a one-size-fits-all solution here. And we know that there are some people who just won't recover the way others do, and it really should be tailored to the individual, and more research should go into understanding why some people tolerate it and why others don't.
So we've got a couple of minutes left, so I want to address something that came through in all of the talks, which was the need for more understanding. And Betty, you I think used the perfect word, which is a bit of compassion. Why is this currently a bit misunderstood? And what can we do to provide better information and make patients feel a bit more supported? That's a difficult question for 2 minutes, but I'm gonna throw that to Krisnah first.
Thanks. I mean, I think it's obviously about us being connected to people with long COVID, constantly getting that information about answers to the questions that we're asking in this panel today, and adjusting what we're doing in terms of support and research based on their input. I mean, just on the last point around post-exertional malaise, it's through hearing from people with long COVID that we've changed our advice. So I'll post something in the chat in a second for all attendees, but even our advice on breathing recognizes that for some people that's going to get worse. So there are techniques that are deliberately recognizing that. So, I mean, obviously we have our website, and obviously I posted my contact details, but we always want to hear more from people with long COVID. So please don't feel like we're not listening, or that your voices aren't being heard. That we want to try and make sure that they're heard by the right people, not just researchers, but even the people funding the research.
Yeah, very important. Danny, final comment before the break.
Yeah, my little bit of wit and wisdom that I think it's just a plea really for a bit of tolerance and understanding, because we've got the perfect group on this call. We've got, a lot of patients and support groups, and also a lot of professionals, sort of medical professionals. And, I can understand both sides. We've got very, very desperate patients who are desperate to restart their lives and get back to normal and work out what the hell is going on and get some help. And on the other side of the table, you've got a terrified healthcare professional, perhaps a junior doctor, who's been plunged into a clinic, has no tests to give, no understanding of the disease process, and a very angry person in front of them and doesn't know what to do for them. So let's just understand each other a little bit.
I think that's an absolutely perfect description of the situation in a lot of countries at the moment. A good message to finish, which is understanding, compassion, and trying to work together to find some solutions. So we're going to take a short break now.